Today we'll be discussing about the malabsorption and malabsorption syndrome in children. I am Dr. Shireen Qasim Bham, Associate Professor, Department of Pediatric at FRPMC. In this lecture, we'll be discussing the malabsorption and malabsorption syndrome. We'll understand the core concept of malabsorption that leads to failure to thrive in children. We'll be discussing the etiology and the pathophysiology of celiac disease. Along with celiac disease, we'll be discussing other causes of malabsorption in children. We'll explain how to evaluate a child with malabsorption, and in briefly, we'll discuss the management of a child with malabsorption or malabsorption syndrome. The term malabsorption basically describes disorders in which there is disruption of digestion and nutrient absorption. It can be a single entity or it can be a part of a multiple or a systemic disease depending on the abnormality. The food must be digested, absorbed, and transported from the villi of the intestinal mucosa into the bloodstream. And anything that disrupts this normal transportation will lead to malabsorption. And malabsorption in children is usually consists of chronic diarrhea, abdominal distension, and failure to thrive, which is the normal triad of malabsorption or malabsorption syndrome. Again, will be as we can see, malabsorption is a defect in the absorption of one or more nutrient, and malabsorption syndrome, it basically comprises of numerous clinical entities that results in chronic diarrhea, abdominal distension, and failure to thrive. Now, as we know that the malabsorption will lead to different defect in absorption, digestion. So, in a digestive system in which the enzymes are necessary for the digestion, they are either diminished or they are absent. For example, in cystic fibrosis, biliary liver disease, or like lactose deficiency. Similarly, when the absorptive power is defected, in which the intestinal mucosal transport system is impaired, then we can have diseases like celiac disease, which is a primary defect, ulcerative colitis, which is a secondary defect, and Hirschsprung disease, which is an obstructive disease, or other than absorption and digestion, we can have an inatrical defect like the short bowel syndrome, in which there is defect or there is abnormality in the inatrical structure of the small intestine. When we discuss the pathophysiology of the malabsorption syndrome, as we know that the digestion is an enzymatic hydrolysis which is initiated by the lots of introluminal processes going on which requiring gastric, pancreatic and biliary secretions. And the final product of all these of digestion are absorbed through the intestinal epithelial mucosal cells. When malabsorption occurs, is the pathological interference in the normal physiological sequence of digestion, that is the intraluminal process, absorption, that is the mucosal process, and then the transport, that is the post-mucosal events of the nutrients. In the stomach, there could be diminished acid secretion, which cannot convert the pepsinogen to pepsin. There could be increased acid secretion, will lead to inactivation of pancreatic enzymes, or it can be a diminished secretions of intrinsic factor. Similarly, in a small intestine, it can damage to the mucosa due to the toxins by any bacteria or any other toxins like the toxin liberated by the bacteria. Damage by the bacteria and protozoa, it can be damaged to the brush borders that will reduce the disaccharidase and non-effective inflammatory diseases. Similarly, in maldigestion, there could be pancreatic insufficiency, it could be bile acid insufficiency, or it could be a disaccharidase insufficiency or deficiency. In large intestine, it can be an infective process that can lead to disruption, or can an immunological inflammation can lead to the function of the large intestine. In this slide, the clinical presentation of malabsorption or malabsorption syndrome, again, as I said, a triad of chronic diarrhea. You can see the abdominal distension. You can see the failure to thrive. There is loose skin folds all over the body. The axillary fold, the inguinal fold, they are all loose. There is distant abdominal distension. Obviously in reality there would be skin lesion. There could be ascites. There will be hair loss, or there would be hypo or hyperpigmentation of the skin. There would be anemia. There would be the signs of micro and macronutrient deficiencies like vitamin A, vitamin E, vitamin K, and obviously uh, in certain systemic disease there could be involvement of the joint as well. When we discuss the epidemiology of malabsorption syndrome, we have genetically determined syndromes. Like in celiac disease, where there is an evidence of genetic transmission. It's a common inherited malabsorption syndrome. And the second most common in children is the cystic fibrosis. There is always a defect in the HLA genes that lead to these diseases. When we talk about acquired syndrome, then it could be in cow milk or soya milk protein allergies, which is very common in our part of the world, because the cow milk or the soya milk are introduced very early in life, and the intestine are not ready to absorb those proteins. Then there is a transient and common form of malabsorption in infant results because of many viral gastroenteritis, that is acute onset enteritis, mostly rotavirus, which causes a transient lactose intolerance, and that lead to uh, chronic diarrhea or in an initial phase of the disease. When we talk about gender difference, then the celiac disease is more common in females. Autoimmune enteropathies, they are also X-linked disorders that only affects the males in familial cases. In When we discuss about age, congenital disease are usually apparent shortly after birth or after a short interval once a particular substance is ingested in substantial amount, like the lactose intolerance. Initially, sometimes it can present as congenitally, as at birth, or sometimes it is after a certain ingestion or certain infection that can lead to lactose intolerance. Protein sensitivity syndrome to milk or soy protein, they are usually present in infant younger than 3 months of age. Then there are solid food protein sensitivity syndrome, which are known to occur in older patients. Now, the most important part of understanding any topic is how the disease present, the clinical presentation that involves basically the history of from the patient. We should obtain a complete history of the patient diet, the amount and the type of fluid, the solid food, and the formula for started at what age and at what time of life. Breastfeeding, when it was introduced, and how many till how many years the breastfeeding was given. The introduction of weaning diet, when it was introduced, with which food they started the weaning diet. Then their history of growth failure. There is consanguinity of marriage, that is a common cause of cystic fibrosis. Then we should know the onset and the duration and the increased frequency of stools, and the character of the stool is very important. In frothy, bulky, greasy, offensive stools are indication of fat malabsorption. Sudden acute diarrhea with vomiting, that is usually an indication of dietary protein intolerance, and watery acidic diarrhea with perianal soreness, that is usually due to the carbohydrate malabsorption. Then we should know the history of relation of diarrhea with cow milks, the solid food introduced, food allergies, food allergy in parents, food allergy in family, other sort of allergies in family should also be known. History of recurrent respiratory tract infection along with GIT symptoms, that is an indication for cystic fibrosis. Then we should also know the history of headache and weakness, the history of oral ulcers, history of rash, history of any arthritis or jaundice. We should also ask in the history of hypertension and renal disease in the family or in this child, history of blood loss, PELAR, and history of peripheral neuropathy. So all these points of history that will lead to, that will help us, or that will lead to a proper differential diagnosis, and then you can go on to proper evaluation of that child, and finally management of this child. The basic laboratory tests that we should do to screen a patient with malabsorption. There are many blood tests, and very important is the stool test. In blood tests, we should go for a CBC and the platelet, complete blood count and the platelet. That will give us an idea about the inflammatory bowel disease, the level of anemia. If there is increased counts of eosinophil, that is eosinophilia, then that gives an indication for food allergy or parasitic infection. Serum albumin and protein that give us an clue towards the end, protein losing enteropathy, protein energy malnutrition, and obviously the chronic liver disease. ESR and CRP, if they are raised, then give an idea about the inflammatory bowel disease. Immunoglobulins that should be done in children with immune deficiency syndrome. Lipid profile should be done for beta lipoproteinemia. Serum IgE usually are done in order to exclude allergy and hyper IgE syndrome. And then we do the stool examination, which is the very important investigation. The stool, usually routine and culture, should both of should be done in order to diagnose any parasitic infection like Giardia, or any bacterial infection with high WBC in the stool. Fecal leukocyte count will differentiate between an inflammatory and a non-inflammatory diarrhea. The fat globules will give us a view about the fat malabsorption. pH and the reducing substance in the stool will give us the clue towards the carbohydrate malabsorption. The stool electrolyte, sodium, potassium chloride, and osmolality, that will give us an idea about the, either it is an osmotic diarrhea if the pH is less than 5, and if pH is more than 5, then it's a secretory diarrhea. Then we can have alpha-1 antitrypsin activity that also give us an idea about the protein losing enteropathy. In the previous slide, the stool analysis is an important part of GI examination. We need to see the reducing substance that gives an indication for carbohydrate malabsorption. Acidic stool again are an indication for carbohydrate malabsorption. Level of quantitative stool fat test should also is also done in order to measure and monitor for the food intake. The intake of the fat is measured and monitored for 3 days. That we will see in the next coming slides. Serum protein, that is the alpha-1 antitrypsin, I told you that is an indication for protein losing enteropathy. And examination, a simple test for examination of ova parasite, especially to exclude chronic giardiasis, is an important part of the examination. Along with these tests, other tests are also done, like the pancreatic function test for like sweat chloride test in order to exclude the cystic fibrosis. There are fetal fat estimation. There is chymotrypsin in the stools. They are also done to see the pancreatic insufficiency. To exclude the carbohydrate malabsorption like lactose, glucose, fructose, and lactulose malabsorption, the hydrogen breath hydrogen tests are also done, which is also part of the GI evaluation. Then in the if other investigations are not giving us any clue or are inconclusive, then we should go for endoscopy, which is an important part of the GI evaluation. Endoscopy will give us the duodenal biopsy that will tell us whether there is any evidence of celiac disease or malnutrition or Crohn's disease. Especially in Crohn's disease, in endoscopy, we'll have the cobblestone appearance on endoscopy. And in celiac disease, we have reduced duodenal fold, scalping of duodenal mucosa, and then we take the biopsy and see the biopsy finding. Sigmoidoscopy and all is also done to exclude the IBD, ulcerative inflammatory bowel disease, and colitis. So endoscopy is an important part of the GI evaluation. Celiac disease is a very common entity in the GI diseases. and it's a very important part of the malabsorption syndrome. Celiac disease is a permanent sensitivity to gluten in a genetically susceptible individual. The disease is an immunologically mediated small intestinal enteropathy or gluten sensitive enteropathy. It is present in both childhood and in adult. It's an adult as well as childhood disease. The mucosal lesion suggests it's a cell-mediated as well as humoral-mediated overstimulation. Cell-mediated mechanism, they have a very specific key role in the induction of the mucosal damage. Celiac disease is more seen in Europe and American white than the Asian. 1 out of 250 individual American association 2001 says in every 250 individual one is having celiac disease. Exact cause is although not known, but there appears to be an inherited predisposition with an influence by the environmental factors. It has also has been shown to have a strong evidence of association with type 1 diabetes, IgA deficiency, autoimmune thyroiditis, Down syndrome, Turner syndrome. It is common in these individuals. The common association with HLA genes like D8, DR3, DR7, DQ2, and DQ8 is also well known. The clinical presentation of celiac disease vary with the age of the patient, duration, and the extent of the disease, and presence or absence of extraintestinal complication. The classic form of celiac disease in children consists of gastrointestinal symptoms starting between the age of 6 to 24 months of age after the introduction of the wheat, that is gluten, in the diet. Usually, the classical characteristics, they are four. That is the steatorrhea, that is fatty, foul, frothy, bulky stools, leading to a general malnutrition, along with abdominal distension, and there would be secondary vitamin deficiency. Usually, infant and young children typically presents with chronic diarrhea, anorexia, abdominal distension, abdominal pain, poor weight gain, weight loss, and vomiting. Older children can present with diarrhea, nausea, vomiting, abdominal pain, bloating, weight loss, and constipation. Sometimes even isolated symptom of constipation can be a presentation of celiac disease, and similarly, isolated presentation of frequent abdominal pain can also be a presentation of a celiac disease. So it has a variety of presentation. When we come to pathophysiology, the disease, as we said, is characterized by intolerance to protein, gluten, which is found in wheat, barley, rye, and oat. So the patients are unable to digest the gliadin component of the gluten, resulting in accumulation of toxic substances that is damaging the mucosal cell. And as we have discussed, that is usually the cell-mediated mechanism plays a key role in the induction of mucosal damage. Clinical manifestation, as we have discussed, um, impaired fat absorption lead to steatorrhea, that is the excessively large, pale, oily, frothy stools. Patient complains that the stools usually uh, they uh, they float in the commode. Exceedingly foul-smelling stools, impaired absorption of nutrients, malnutrition, anemia, and anorexia, abdominal distension, and muscle wasting because of malnutrition, protein loss, and there is the wasting is prominent in the legs and the buttock area. As for uh, the manifestations, we have discussed the gastrointestinal part, the extra intestinal manifestations. They are common in children who present late. In these children, we can have short stature, iron deficiency, anemia, which is resistant to oral iron supplementation, is the very commonest presentation. Along with that, there can be skeletal abnormalities like delicate osteoporosis, enamel hypoplasia of teeth because of the obviously malabsorption of vitamin D and calcium. Muscular, there would be muscular atrophy because of malnutrition. Neurological symptoms, the patient can have peripheral neuropathy, epilepsy, irritability, cerebral calcification, cerebral ataxia because of the vitamin B12 thiamine deficiency. Endocrinologically, the child can present with only as short stature. Many children who are presenting with short stature, failure to thrive when they are investigated, they comes out to be positive for celiac disease. Puberty issues and secondary hyperparathyroidism because of vitamin D malabsorption. Skin manifestations as dermatitis herpetiformis, alopecia areata, and erythema nodosum is again a part of the autoimmune disease. And then there can be an respiratory symptom like idiopathic pulmonary hemocirrhosis, which is very least common. But the common usually the signs are peripheral edema, clubbing, smooth tongue because of the deficiency of vitamin B12, long eyelashes, and delayed dentition. So these are the common signs that children can present, the children of celiac disease can present. Other manifestations like irritability, fretfulness, apathy, uncooperativeness, that is because of the iron deficiency and other vitamin deficiency. There is a term which is usually used, that is the celiac crisis, in which there is an acute, severe episodes of profuse watery diarrhea and dehydration, vomiting, and infection, especially secondary to any gastroenteritis, prolonged fluid electrolyte depletion, and emotional disturbances. So celiac crisis needs emergency treatment of these children. Now, there is a spectrum of celiac disease. When we say celiac disease, it does not mean that it's a symptomatic every time. It can be a silent one, it can be a latent one, it can be a potential one. Symptomatic, when we say symptomatic, there is frank malabsorption symptoms like chronic diarrhea, failure to thrive, weight loss, and there are other extra-intestinal manifestations. When we say silent, then there is no apparent symptom in spite of histological evidence of villus atrophy, and in most cases identified by the serological screening uh, of these children, of high-risk children. Then there are latent, like subjects who have a normal histology, but at some other time, before or after, they can have a gluten-dependent enteropathy. So they are basically a silent individuals with a normal histology, but because of any time in their life, because of any predisposing condition or any infection, that can lead to gluten-dependent enteropathy later in the life. Does not mean that this child will have celiac disease from birth, but he is predisposed to having celiac disease later in life. Then there are potential subject with positive celiac disease serology, but without the evidence of altered jejunal histology. It might or might not be symptomatic. So there are many conditions that we call it non-gluten enteropathy. So there are other terms which are also related to celiac disease that is not due to gluten. They don't have any altered jejunal histology, but they have a positive celiac disease. Diagnostic evaluation is specific to the celiac disease includes serological tests and the histopathological changes in the intestinal mucosa. For serological tests, the commercially available tests are the um, anti-tissue transglutaminase antibodies IgA and IgG. IgA having 92 to 97% specificity and IgG having 50% specificity. Along with these antibodies, we also have anti-gliadin IgA and IgG antibody and anti-endomysian IgA antibodies, which are obviously expensive and we don't use them here in our country. Obviously, after the serological test, after the for the confirmation of the diagnosis of celiac disease, we need the uh, an endoscopy, and through the endoscopy, we need the intestinal biopsy is required in all the cases. Now, the differential diagnosis of the villus changes in the developing countries can be due to cow milk protein intolerance, tropical sprue, severe protein energy malnutrition, persistent GI infection. So, therefore, we need to confirm these positive serological tests with an intestinal biopsy. And the endoscopy usually shows the scalloping of the small bowel loops and cracked mud appearance of the mucosa. As per the Aspagan criteria, that is the European Society of Pediatric Gastroenterology and Nutrition, uh, gold standard is the intestinal biopsy, which is required in all the cases. As the histological changes in celiac disease may be patchy, so it is recommended that the multiple biopsy specimen be obtained from the second and more distal part of the duodenum. There is a good evidence that the villus atrophy is a characteristic histopathological feature of celiac disease, but there can be infertative changes in the submucosa. The two main requirement that is mandatory for the diagnosis of celiac disease is the villus atrophy with hyperplasia of the crypts and abnormal surface epithelium while the patient is eating adequate amounts of gluten, and a full clinical and histological remission after withdrawal of the gluten from the diet. For the histological evaluation, we use the Marsh criteria. It has different grading of the histological features. You need not to memorize all these findings, but you just need to know what is the Marsh criteria. That Marsh criteria basically gives the histological features, the grading of the histological features. Uh, This is the another slide which shows a healthy intestinal mucosa and a mucosa of a patient with celiac disease. You can see the villus atrophy. The size of the villus has been reduced. The inflammatory process, which is mediated by the T cell, this causes the disruption of the structure and function of the mucosal lining that will lead to malabsorption. So the three important features that we already discussed is the blunting of the villi, crypt hypertrophy, and lymphocytic infiltration intraepithelial, which is significantly can be seen the blackish spot in the epithelium. Uh, Inside the epithelium, you can see the intraepithelial lymphocytic infiltrations. A positive serological test that reverts to negative after the treatment with a strict gluten-free diet in such case is further supportive evidence for the diagnosis of celiac disease. Sometime in patients with selective IgA deficiency, serological diagnosis may become difficult as IgA antibodies will be absent or negative. So, in patients who are strongly suspected to be celiac disease, but regular IgA based marker is negative, IgA level should be done. IgG antibody tests along with intestinal biopsy are needed for the diagnosis of celiac disease in these cases where there is IgA deficiency. So always when we send the patient for the uh, transglutaminase IgA and IgG antibodies, we usually also ask them to do an Ig serum IgA antibodies in order to exclude isolated IgA deficiency. Now, regarding the management of celiac disease, treatment with a strict gluten free diet is recommended for all symptomatic children with characteristic intestinal histopathological abnormalities, and also for asymptomatic children with a condition associated with celiac disease and having histological findings on a small intestinal biopsy. The gluten free diet is a lifelong treatment, and that's the only scientifically proven treatment available for the symptomatic individual with celiac disease. It is recommended that the treatment be started only after the diagnosis has been confirmed by the intestinal biopsy. Even a small amount of gluten containing grains like wheat, rye, and barley, they are to be avoided, and they are, if they are ingested on a regular basis, will lead to mucosal changes in the intestinal biopsy and persistent of the clinical symptoms. Rice, maize, and corn, they are non-toxic and they act as wheat substitutes. The clinical response to gluten withdrawal is dramatic. The growth velocity improves rapidly. The major problem is of non-compliance, especially in teenagers when they are growing up. The patient as well as the parent, they should be counseled for the long term complication if the patient is non compliant or if the patient does not uses the gluten free diet. Supportive nutritional deficiencies are treated with appropriate supplements, including the vitamins, iron therapies, and the calories which is required for these patients in the initial stages when the gluten-free diet is added to the diet. Prognosis of this child, it is obviously varies among children, and it is also recommended to measure the transglutaminase antibodies after 6 months of treatment with the gluten-free diet to demonstrate a decrease in the antibody titers as an indirect indicator of dietary adherence and recovery. Obviously, children with celiac disease, they are monitored periodically for assessment of symptoms, for growth and physical examination, and also to see the compliance to gluten-free diet, adherence to the gluten-free diet. The most serious complication that usually occurs is the lymphoma, but a strict dietary avoidance of gluten prevents symptoms and may minimize the risk of uh, delivery lymphoma. Lactose insufficiency or lactose intolerance is also common in children. It could be a primary or it could be a secondary lactose deficiency. Usually, lactose-free milk is the only solution which relieves the symptoms of the children. The other is the milk allergy to cow milk protein, and obviously removal of the cow milk protein from the diet reduces the symptoms of the patient. Uh, in cases of lactose deficiency, to limit the intake of lactose to a level that can be tolerated, usually 12 grams of lactose per sitting. Other dairy products like butter, yogurt, and cheese are well tolerated. Other substitute can be soya milk, almond milk, or coconut milk, and there are some commercially available lactase enzymes are also now being used. Beta lactidose, galactosidase are also being used. Another inherited disorder, that is the cystic fibrosis, which is inherited as autosomal recessive transmission. It is one of the common lethal genetic disease in Caucasian. It is because of the cystic fibrosis transmembrane conductor regulator defect on chromosome 7. There are around 400 mutations of cystic fibrosis locus, of which the delta 508 deletion genotype is the commonest. The mutation basically affects the gene protein product cystic fibrosis transmembrane regulator CFTR, which act as a chloride channel regulator and affects other aspects of transmembrane movement of water and ions, leading to inadequate hydration, resulting in thick secretion of the exocrine gland. Pancreatic insufficiency occurs because the amigatic enzymes, they stay in the duct and are activated intraductally. Autolysis of pancreas takes place and there is inflammation and calcification and fibrosis. Intestinal abnormality, the newborns which are predisposed to cystic fibrosis, they can present with meconium ileus, distal intestinal obstructive syndrome, and rectal prolapse. Usually, these children basically present with malabsorption, failure to thrive, and deficiency of fat soluble vitamins. Usually, patient presents with hypoproteinemic edema. They will have shrunken cystic pancreas leading to recurrent pancreatitis. The diagnostic test is the sweat chloride test and the delta 508 gene, which can be done, and that can diagnose the disease and that can be treated. The malabsorption basically have a negative consequences on the nutrition status of the children. The children will start reducing their weight. Initially, they will have reduce in weight gain, and then followed by the growth. There is slowing down of the growth rate. There is prominent loss of subcutaneous fat with muscle wasting. In children who have the in which the liver is affected, you can have vitamin K deficiency and can present with hemorrhagic manifestations. In children with Crohn and celiac disease, you can have anorexia that will lead to a further malabsorption. chronic inflammation, protein using enteropathy, all these conditions will lead to low IGF level, but normal growth hormone leading to growth failure. There is deficiency of fat soluble vitamin A, D, E, and K, which is significantly affects the multiple organs. Acidosis is a usual presentation in these malnourished children because of the deficiency of vitamin B12, B complex, iron, and folate level. You can see the sore lips, the angles of the mouth are uh, prominently sore, and that makes them difficult to eat. There is also the epithelium of the tongue is also changed, and there is also some signs of glossitis. There is the absence of pepla in this tongue, followed by glossitis, which is deficiency of again B12, iron, folate, and niacin. You can see there is swelling, there is beefy red tongue, and there is absence of pepla in the major parts of the tongue that lead to glossitis. Then you have endodermatitis enthopathica, that is exclusively because of the deficiency of zinc. Malabsorption lead to zinc deficiency, and zinc basically affects the facial skin and the dimple area, which is the prominently affected by because of the absence of zinc intake in these children. For this is approach to suspected malabsorption. We should have a detailed dietary history. We should have a proper detailed focus examination of the child, from head to toe examination with signs of micro and macronutrient deficiencies. Then we should go for routine screening lab tests, and then go for a stool analysis, complete stool analysis, which basically defines many abnormalities. And then we can go for selective tests based on the findings, like hydrogen bread tests. We can do for celiac abnormality, you can do the abdominal imaging, you can do the ERCP or the fecal alpha 1 antitrypsin, and then treat based on the underlying disease or the type of malabsorption. Thank you so much. If you have any question or regarding the topic, you can email me at my email address, or you can contact me personally for any query. Thank you so much.